Thank you very much, Dr. Shell, and as always, it's an honor and pleasure to be a part of this course. As already mentioned, cataract, a standalone cataract surgery is a very rewarding surgery. But when there are comorbid conditions, and specifically if I may talk about uveitis, there are several other factors which will influence the outcome. And the traditional thought process that patients have of clear vision, expedited recovery the next day often doesn't take place. So thankfully, there are a lot of advances, both technological and pharmacological, which help us give patients almost the same outcome, if not the exact same outcome that they would have with a conventional cataract surgery. So this is just something, and this patient was advised cataract surgery elsewhere. The report said old cells and flare, but there was very active uveitis. This was a monocular patient with very evident vitritis and fibrosis synechia in the anterior segment as well. So in the first step to the handling of a uveitic cataract is control of inflammation. So I'm just going to have a couple of case illustrations to put things in perspective. So this was a 57-year-old lady. This is a separate case, of course, who presented to us with decreased vision in the left eye since a month. She had a similar complaint 1 year ago, which resolved with some local therapy, and was diagnosed to have macular edema elsewhere, and had been given topical NSAIDs. So she sought a second opinion. FFA was done elsewhere and was diagnosed to have cystoid macular edema. The vision, as you can see, was affected in both eyes, but especially the left eye. And in the anterior segment, there was obvious posterior synechia with cells, active cells and flare, as well as vitreous cells. So this is the picture that we see here, and what you see there is actually exudates and a lot of edema as well with subretinal fluid. So this is just a succinct picture to show the course. So as you can see, I don't know if you can see the, do we have a pointer? But initially we treated the patient for uveitis. So she had posterior uveitis, and that resolved with the dexamethasone implant. Subsequently, she developed a cataract, underwent uneventful cataract surgery, had a recurrence post-cataract surgery, and was treated with a second injection. This is yet another lady who again had been advised cataract surgery elsewhere, but had also complaints of blurred vision, metamorphopsia, and so on and so forth. So the angiography and the OCT scans confirmed the presence of cystoid macular edema, which could only be explained by posterior uveitis. She underwent first treatment again with the dexamethasone implant. As a rule, we try and avoid systemic therapy as far as possible. And eventually, we found out that the husband had a course of AKT 10 years ago. She herself had a positive Mantoux, underwent AKT, a full course, and eventually was diagnosed to have cataract, and she received both a combined cataract and intravitreal injection. So in the interest of time, I'll just skip through the photos. But anyway, the third thing that we have to remember during cataract surgery, apart from the inflammation, of course, is there are other challenges. For example, posterior pupillary synechia, additional instrumentation is required, such as iris hooks or pupil expanders. Often the capsule is fibrotic. There's a posterior capsular plaque. There might be associated vitritis, which may make the view a little murky. And most importantly, any recurrence in such eyes can be extremely intense. So a period of quiescence ranging anywhere between 3 to 6 months is desirable before we opt for cataract surgery in uveitic patients. And this is the prime example of this patient. So everything else resolved, but then he had this epiretinal membrane. It was diagnosed. Ultimately, he needed vitrectomy and membrane removal. The edema persisted. It was only after the implantation of an intravitreal dexamethasone implant that the edema subsided to give a satisfactory reaction. So we have had the fortune of conducting a randomized trial. It was a sponsored trial wherein we compared the dexamethasone implant with systemic steroids. So just skipping to the results in the interest of time, both groups showed excellent visual gain throughout. Most importantly, there was only one recurrence in the dexamethasone implant group out of 20 or 23 patients who needed intervention with systemic steroids. Otherwise, all patients, when we take into consideration the period of quiescence, were managed very well solely with local therapy and not with systemic therapy. So the whole goal is to prevent systemic side effects of oral immunosuppression and concentrate as far as possible on the tissue which is involved. Now, I'm just going to show two videos because this is an increasingly common situation. The first shows how to combine an intravitreal dexamethasone implant with cataract surgery. So at the end of the surgery, generally it is given in the inferotemporal quadrant, bevel facing downwards. And we choose to remove the viscodispersive, any dispersive viscoelastic that you have after injection, because it helps seal the ports of entry during cataract surgery. And it is then that you finish your hydration. If these rules are not followed, the second video shows how not to inject and what to do in case you have a problem. So here, as you can see, the lens is going in. Now the surgeon chooses to remove the viscoelastic prior to injection of the dexamethasone implant. And if you see the position of the bevel, you will see it shortly in the lower part of the screen. The bevel is facing upwards. The direction of the needle is not vertical or perpendicular, it is towards the capsule. And eventually the dexamethasone implant lands up in the posterior capsule. Now, because the surgeon was extremely skilled, he was able to do a reverse optic capture, and ultimately the patient had an excellent outcome. But this is a scary situation, and for a moment you can go blank. So the best is just to stick to the basics, stick to your the technique, and make sure that you don't have to face this situation at all. Now I keep repeating, talking about the dexamethasone implant, but obviously in India not everybody can afford it, and so subtenon triamcinolone or even intravitreal triamcinolone is a convenient and effective alternative and a cheaper alternative. The subtenon route, and we have found it to be very effective. It's just that it has to be in the right plane. So we actually do a conjunctivotomy and a tenotomy and go in with a visco cannula to inject triamcinolone in the subtenon space. So this has two benefits, as per our experience. One is you are in the subtenon plane. Number two, there is no chance of perforation because you are not using a sharp instrument. And ultimately, if it is in the subtenon space, there is a very little chance of any IOP spike. So overall, if you look at our paper, and we have collaborated with several European institutes, there were about 152 eyes that received overall 358 dexamethasone injections. The mean gain in BCA was quite satisfactory, and more than a third gained 15 letters or more. 40% patients eventually needed cataract surgery, and the approximate time from first injection to cataract surgery was about 11 months. Nearly a quarter of those patients needed IOP lowering therapy, but no one received incisional surgery for glaucoma. So steroids can be both given perioperatively in pseudophakic patients, in anti-VEGF resistance, and so on and so forth. But the most important thing is local steroid therapy is the current focus. So I thank you all for your attention, and I would love to take any questions.
Excellent presentation, Dr. Aditya. Aditya, we as cataract surgeons, predominantly doing cataract surgery, are very scared that, if the patient has had uveitis for multiple episodes, synechiae, should we put the patient on atropine post-operatively? Should we start him 3-4 days prior on oral steroids and continue it? So what's your take on all of that?
So if the uveitic part has been quiescent for at least 3 months or so, we can readily combine the patient's cataract surgery with some form of intraocular therapy. It can either be an intravitreal dexamethasone implant, or it can be intravitreal triamcinolone, which is not preferred because of the high IOP, right? And if the patient cannot afford a dexamethasone implant, a subtenon triamcinolone injection is very effective.
So I think one of the important take-home messages that I gained from this talk is that the role of heavy dose systemic steroids in a relatively quiet uveitic eye undergoing cataract surgery may not be necessary, particularly keeping in mind the age group at which most of these patients are getting operated.
Keeping in mind their systemic comorbidities.
Exactly.
So systemic steroids can readily be replaced. In fact, let me give you a reverse example. So we were recently treating a sympathetic ophthalmitis case. Obviously, one-eyed patient, the other was lost to trauma or something, and that's why she developed. So the patient had received pulse methylprednisolone therapy, 1 gram for 3 days, and was on systemic steroids. Even then, the lumpy, bumpy appearance of the choroid that we described had not disappeared after 10 or 15 days of intense therapy. We put in one intravitreal dexamethasone implant, which in Gujarat is sanctioned even by the Gujarat government in certain cases. And within 4 days, the choroid was flat. So the role of local therapy cannot be overemphasized. It is not only a very good addendum to systemic therapy, sometimes it suffices as sole therapy.
Thank you so much